All right, we're going to go ahead and get started. Hello, everyone. Good morning, good afternoon, and good evening. Thank you for joining us for our August of 2020 Global One Health Initiative webinar supported by the NIH Fogarty International Center. Our theme for this webinar is Virology, Co-infection, and Immunity, and we'll be hearing from Dr. Robert GOHi of The Ohio State University Comprehensive Cancer Center and GOHi Executive Committee member, as well as Debasu Damti, a PhD fellow of the University of Gondar's College of Medicine and Health Sciences in Ethiopia, and an OHART fellow doing part of his research here at The Ohio State University, as well as a longtime partner of the Global One Health Initiative. And this webinar will be moderated by Dr. Prosper Boyaka of The Ohio State University College of Veterinary Medicine. And with that, I will hand it over to you, Debasu.
Okay, thank you very much, Dr. Laura, for your introduction. My name is Debasu Damte, and I am a PhD fellow at Ohio State at University of Gondar, and currently a research fellow at Ohio State University. I will be talking on epidemiology of Hepatitis B virus infection in HIV patients, and I'll be focusing on Ethiopian context based on some research work done before I came here. I will focus on introduction and Hepatitis B virus epidemiology in HIV patients, its prevalence, genotypes of the Hepatitis B virus, drug resistance mutations, and occult Hepatitis B virus in HIV patients. To begin with the introduction, since the emergence of HIV in early 1980s, 75 million people have been infected with HIV virus, and about 32 million people have died of HIV. And currently, an estimated 0.8% of adults worldwide are living with HIV. And this figure is much higher in developing countries. And if we consider African region, which remains most severely affected with 3.9% of its population living with HIV. And according to this figure, the WHO African region accounts for more than 2/3 of the people living with HIV worldwide. And if we see the summary of global HIV epidemic in 2018 only, there were about 37.9 million people living with HIV in 2018, and 1.7 million people were newly infected by the same year, and it was around 770,000 people died due to HIV-related conditions by the same year. So HIV is a member of lentivirus family of animal retrovirus, and it causes long-term latent infection and short-term cytopathic effects. And the disease is characterized by profound immunosuppression with associated opportunistic infection that ultimately will lead to development of AIDS disease. And it mainly affects the CD4 T cells and macrophages and dendritic cells, which are very important immune components that will suppress the immunity of the infected person. So when we see the immune response to HIV in general, it is ineffective. However, early response to HIV seems quite similar with immune response to other viruses, which involves interferons, defenses, natural killer cells, dendritic cells, and complement components, which are of non-specific immune response to any virus. And this will be followed by initial adaptive immune response that involves expansion of CD8 T cells. And these cytotoxic T cells, which are specific to HIV, can control the infection in early stage. However, after the development of mutant strains or emergence of mutant strains of HIV, the CD8 T cells or cytotoxic T cells will no more control the virus. And there will be also early antibodies are produced against some antigens of the virus, which are of non-neutralizing type. They cannot control the infection. However, there will be antibody production of non-neutralizing type. But later in the infection process, neutralizing antibodies to glycoprotein 120 are produced within 2 to 3 months. And we call this period basically a window period. If we are interested to diagnose HIV patients using antibodies specific to glycoprotein 120, we need to consider this window period so that we cannot find false negative results. So when I come to Hepatitis B virus, the virus belongs to the genus Orthohepatidina virus and a member of Epidemiology family. And the genome size is about 3.2 kilobase. It is the smallest DNA virus with circular, partially duplex DNA molecule. And this virus contains a condensed coding region with 4 overlapping operating frames, namely operating frame for polymerase, core antigen, surface antigen, and gene X. So it's a very small virus among the DNA viruses having overlapping DNA spaces. When we see the epidemiology of Hepatitis B virus is a major global health problem, and more than 240 million people are Hepatitis B surface antigen positive, chronic Hepatitis B carriers that will give a higher risk of cirrhosis and hepatocellular cancer. And the prevalence of chronic hepatitis virus greatly varies worldwide, which ranges from 0.5 to 20%. Southeast Asia and Sub-Saharan Africa region being the worst affected regions globally. And when we see the hepatitis B virus HIV co-infection, persons living with HIV have a disproportionate high burden of hepatitis B virus infection, as these two viruses share risk factors, transmission modes, and endemicity. The co-infection is disproportionately high in developing countries, and approximately 10% of HIV-infected people have chronic hepatitis B virus infection. And HIV increases mortality from cirrhosis and end-stage liver disease in hepatitis B virus co-infection. So on a study to estimate liver disease-related mortality has reported that hepatitis B virus HIV co-infected patients was 14.2 per 1,000 person year liver-related mortality, with hepatitis B virus or HIV mono-infected ones were only 0.8 and 1.7 per 1,000 person year liver-related mortality respectively. So that we can see from here that the co-infection or the coexistence of these two viruses in a patient will maximize the risk of liver-related mortality in patients. In Sub-Saharan Africa, hepatitis B virus infection status of most HIV patients is unknown, and hepatitis B virus HIV co-infected patients are often treated with lamivudine or 3TC, which is one of the nucleotide analog used for the treatment of HIV. And in chronic hepatitis B virus, treatment with first generation nucleotide analog, such as 3TC, leads to high rate of drug resistance mutations in over 20%. And 3TC resistance can confer, of course, cross resistance to other anti-hepatitis B virus drugs or agents. And most experts, therefore, treatment guidelines recommend dual active nucleotide analog with higher genetic barrier to resistance for hepatitis B virus HIV co-infection. So it's not, this 3TC is not the only drug that should be given to a co-infected patient. There should be also other drugs considered to treat hepatitis B virus HIV co-infected patients. When we see the overlapping epidemiology of HIV and hepatitis B virus, as you can see from this figure, the distribution of HIV is high in developing countries, in Africa region, South America region, and some Asian region. And similarly, to the left map, you can see the distribution of Hepatitis B virus being higher in Africa region and Asian region, since these two viruses share the same transmission mode and risk factors. They do coexist in similar geographical areas. In Ethiopia, there is limited information about Hepatitis B virus HIV co-infection, and most Hepatitis B virus prevalence estimates were based on studies among pregnant women and blood donors. Of course, there are some results from healthcare waste handlers, and some studies in Ethiopia have estimated the prevalence rates of Hepatitis B virus in HIV positive patients at 3 to 5.9% prevalence. So when we see some of the recommendations from WHO regarding Hepatitis B virus HIV co-infection, screening of all HIV patients for viral hepatitis, vaccination against Hepatitis B virus in non-immune individuals, providing anti-Hepatitis B virus therapy for co-infected patients are recommended by the WHO. However, in Ethiopia, HIV positive patients do not undergo routine testing for Hepatitis B virus co-infection, and universal childhood Hepatitis B virus vaccination was not offered until 2008, and therefore timely update for Hepatitis B virus infection in HIV patients would impact prevention and treatment strategies in Ethiopia, and therefore we investigate the prevalence of Hepatitis B virus genotypes and Hepatitis B virus drug resistance mutations in a cohort of HIV infected patients in Ethiopia. So we considered the cohort of HIV patients with 326, and we excluded 18 out of these due to hemolysis and incomplete data. And when we dichotomize them based on their heart status, 290 of them were on heart, while 18 were heart naive. And we screen these cohorts of HIV patients for Hepatitis B surface antigen ELISA, and none of the heart naive group had reactive results, while 17 out of the 290 patients had reactive results for Hepatitis B surface antigen, which gives rise to 5.5% of Hepatitis B virus surface antigen positivity. And this figure is quite in the range between the previous studies reported, which is from 3% to 5.9% prevalence. So when we see the Hepatitis B virus genotypes, basically the knowledge of Hepatitis B virus genotype has gained special attention because it is essential in predicting Hepatitis B virus transmission mode, response to treatment, and disease progression. For example, genotype B and C are known to be transmitted vertically than other genotypes. And in terms of treatment response for interferon-based treatments, genotype is believed to be a good responder for interferon-based treatments than others. And of course, severe hepatitis or hepatocellular carcinoma and cirrhosis are mostly related to genotype A and D than B and C. So it tells a lot about the disease progression and treatment, as well as Hepatitis B virus transmission mode. So we have identified that genotype A is a predominant genotype in the identified Hepatitis B virus strains in our study. So when we see the distribution, basically globally, the distribution is variable. You can see in Canada is dominated by genotype B, and in Russia you can see it's also dominated by genotype D, and in African region genotype E, A, and D are the dominant ones. So all this tells us the predominant transmission modes, as well as the risks of developing severe hepatitis or hepatocellular carcinoma and cirrhosis. The other thing that we looked into was related to drug resistance mutations of the polymerase or reverse transcriptase gene. So there are different mutations that may confer the virus to be resistant to different anti-hepatitis B virus drugs. For lamivudine, there are multiple drug resistance mutations. And of course, some of the drug resistance mutations may confer cross resistance to other same drug resistance mutations. So we have identified drug resistance mutations in 7 of the 13 strains in our condition, and frequent hepatitis B virus drug resistance mutations was found in the substitution of L with M at 180 amino acid sequence, which accounts about 53.8% of the strains, followed by V with L substitution, for which accounts 46.2% of the strains, and M with V at 204, which accounts the same figure, 46.2%. And 5 out of the 7 patients with drug resistance mutations were receiving 3TC as the only anti-hepatitis B virus agent. So unless this 3TCs combined with other drug, it may lead to drug resistance mutations in the polymerase and reverse transcriptase region of the virus. So when we see the phylogenetic tree based on the polymerase reverse transcriptase gene from hepatitis B virus HIV infected patients in Ethiopia, most isolates cluster together, while one strain clusters itself with a genotype B of a Sudan strain. And this is because the sample we collected, or the study area that we have collected the sample, shares a border with Sudan. So there is a free movement of people from Sudan to Ethiopia and vice versa, which may favor the distribution of same strain of hepatitis B virus in the border area. So the other thing is occult hepatitis B virus infection. Occult hepatitis B virus has been increasingly recognized over the last 2 decades as public health concern, and it is characterized by the presence of hepatitis B virus DNA in the absence of detectable hepatitis B surface antigen in serum. So if we look at the interpretation of serological tests for hepatitis B virus, if the hepatitis B virus surface antigen is negative and anti-hepatitis B virus core positive and anti-hepatitis B virus surface negative, there could be different possibilities for interpretation, and among them, low level or chronic infection due to hepatitis B virus could be one of the reasons for this kind of results, having anti-hepatitis B virus core positive results but negative for anti-hepatitis B virus surface and hepatitis B virus surface antigen. So if we do further DNA test or PCR and found the patient positive for that, we call that occult hepatitis B virus infection, unless we find positive hepatitis B virus surface antigen, and if we find them to be positive for anti-hepatitis B virus core followed by DNA or nucleic acid for hepatitis B virus through PCR test, we call them occult hepatitis B virus positive. So occult hepatitis B virus infection has been associated with the development of hepatocellular carcinoma, and occult hepatitis B virus infection is associated with severe liver damage and progression of the liver lesion to cirrhosis, either through chronic inflammation or through direct involvement of the virus in mutation of the host cell. Occult hepatitis B infection is common in HIV infected patients, as it was reported by different scholars. Coffin et al. Has shown 17.8% prevalence of occult hepatitis B virus in HIV patients, and with Italy reported 47% prevalence of occult hepatitis B virus patients in HIV patients. Occult hepatitis B virus is associated with adverse clinical outcomes, including hepatocellular carcinoma, and the burden of hepatitis B virus is particularly high in low and middle income countries such as sub-Saharan Africa. And most people infected with this virus remain unaware of their status, as it cannot be diagnosed by serological tests only. So we have considered the same cohort to study the occult hepatitis B virus infection in HIV patients, and we consider hepatitis B virus surface antigen negative group, and we screened them for anti-hepatitis B virus core first, and we found 115 being positive for anti-hepatitis B core. And from this, when we do PCR for hepatitis B virus DNA, we found 22 patients being positive for hepatitis B virus DNA. And further, we do sequencing for S gene, P gene, and core and pre-core gene to identify reactivation mutations and drug resistance mutation, as well as risks for hepatocellular carcinoma markers. So in our occult hepatitis B virus study, we found 90% of anti-hepatitis B virus core positive patients found to be occult hepatitis B virus positive. In this study, we were also able to PCR amplify and sequence all 22 occult hepatitis B virus positive type patients, and hepatitis B virus genotype D was predominant among occult hepatitis B virus positive patients, which accounts around 81%. And unlike the overt hepatitis B virus patients, we found in that case, genotype A was the dominant genotype, but in occult hepatitis B virus, genotype D was found to be the dominant genotype. And when we see the hepatitis B virus mutational analysis, S gene mutation associated with hepatitis B virus reactivation were detected in 3 patients, around 14%, and anti-hepatitis B virus drug resistance mutations of different type were detected in 5 patients, which accounts 23%. And these mutations were associated with 3TC, etecavir, and or TDF resistance. And mutations for 3TC and etecavir resistance were detected in patients who had not received ART and anti-hepatitis virus therapy. This may indicate that the resistance strains are already circulating in the community even before they receive anti-hepatitis B virus therapy. And mutations of TDF resistance was detected in 1 patient who was on 3TC therapy for about 6 years. And mutations associated with liver cirrhosis and hepatocellular carcinoma risk in pre and core region were detected in 10 of the patients, which accounts around 45%, it's very high. And we had only 1 mutation in the pre-core region, which is W28, was detected in 1 out of 10 patients, whereas hepatitis B virus core mutation were detected in 9 of the 10 patients. To conclude, our study found the prevalence of hepatitis B virus in HIV patients at University of Gondar Hospital, Ethiopia, was high intermediate. It is in this category, high intermediate. And we found a high rate of occult hepatitis B virus in anti-hepatitis B virus core positive and hepatitis B virus surface antigen negative HIV patients. The dominant hepatitis B virus genotypes are genotype A and D in overt and occult hepatitis B virus infections, respectively. And most were receiving first generation anti-hepatitis B virus therapy with a low genetic barrier to resistance and several carried mutations associated with anti-hepatitis B virus drug resistance, and high rates of mutation associated with hepatitis B virus reactivation, drug resistance, and hepatocellular carcinoma risk were detected in these patients. And this data underscores the importance of integrating hepatitis B virus screening to the HIV treatment guidelines for better management and prevention of Hepatitis B virus-related liver diseases. And occult hepatitis B virus screening should be performed in HIV positive patients for better management and prevention of hepatitis B virus-related liver diseases. And World Hepatitis Virus Day was celebrated on July 28th with the theme hepatitis free future. So my message is let's build hepatitis free future by linking hepatitis B virus patients to the clinics for treatment and management. And finally, I would like to acknowledge GOHi OHeart Program, OSCU, GOHi Regional Office, NIH for Garity, and the research teams for the research work, and University of Gondar and University of Calgary for being collaborator for our research work. And I thank you all for listening. Thank you.
Thank you so much, Dabasu, for your wonderful presentation. Unfortunately, it seems that Dr. Baiocchi has been called onto service. So we will then go ahead and proceed with questions for Dabasu, if that's all right with you, Dr. Boyaka and Dabasu.
Yeah, okay.
Oh, no problem with me, yeah.
Okay,
Okay.
apologize. All right, so if you have questions, then can you please enter them in the Q&A box or raise your hand and we will unmute you. Thank you.
Okay, so what I can read, I'm reading already, there's a question from one attendee. I think it's a nationwide seroprevalence of hepatitis B virus infection in Ethiopia population-based cross-sectional study conducted at the Ethiopian Public Health Institute in 2017 found the prevalence of HPV infection to be high.
Mm-hmm.
And the number is given, that is 9.4%. So I don't think this is really a question. This is more like a comment. So the Basu, if I summarize the question or the comment, it says, do you agree basically that with the data from the surveillance that were conducted by the Ethiopian Public Health Institute in 2017, about 9.4%? Or do you have anything to say about the number?
Okay, thank you very much. Basically, the prevalence of this virus may vary from community to community, and basically it's believed to be higher in HIV patients and pregnant women, and most studies focus particularly on pregnant women, and in healthy adults. Actually, studies have been done on healthy blood donors, but mostly, you know, the results are around 5, 4. Even in our previous study in HIV patients, it was close to 4% healthy adults, basically. But the result may happen to be 9.4, and I cannot say it cannot be this big. But in principle, from literatures, what I have reviewed is the prevalence is higher in immunocompromised people, particularly pregnant women and HIV patients. But in some conditions, the figure may be higher even in general population if the people involved in the study have higher risk factors than the specific risk groups that we study.
Yeah, and something else that, you know, maybe I can mention is that you were referring to a specific population in Gondar, I think.
Yeah.
Yes, and the study that is actually referenced here, it just say Ethiopian Public Health Institute, but it didn't give any idea about the area where this prevalence was studied. So
yeah,
that
it's
may
a
be
national.
fair. That may be fair
from
the location. Yeah,
that's true.
So there's another question from the audience where they, which is, how to plan adult vaccination for unvaccinated or partially vaccinated adults associated with healthcare services. So basically, knowing what you know now about HIV and HPV infection prevalence among HIV patients, how would you consider planning vaccination to protect healthcare providers?
Yeah, basically the government of Ethiopia has launched a vaccination coverage for risk groups, and one of the risk groups from adults is the healthcare workers.
Mm-hmm.
And if I consider our own hospital, University of Gondar Hospital, the hospital is providing vaccination for all healthcare workers involved in the system. So it's currently recommended to healthcare workers who might have higher risk of acquiring the virus due to their work. So it's being implemented in most health facilities in Ethiopia. Otherwise, it's only given to children, and now it is part of the expanded program on immunization in Ethiopia, currently given for children.
Yeah, so I had a question that is, I was very intrigued by your discussion of the occult HPV infections.
Mm-hmm.
So the question I have is, do you think it's, or do you know whether there's any relation or correlation with the increase in antiviral treatment, anti-HIV treatment?
Mm-hmm. Yeah, basically most anti-HIV treatments, actually few antiviral treatments may also have activity against Hepatitis B virus treatment, namely the 3TC or lamivudine and TDF or tenofovir-based HIV treatment regimens have anti-Hepatitis B virus activity. Mm-hmm. Therefore, if the patient is taking these drugs, it may lower the nucleic acids or the DNA of this Hepatitis B virus. Therefore, it may be related with low level of expression of these surface antigens.
Okay.
It may be related to anti-Hepatitis B virus treatment.
So is there anything that was done, with regard to the antivirals, that anti-HIV treatment that people were getting? I'm really thinking about to have an idea whether the mutation in the HPV, genome that
Mm-hmm.
you see can be related to a pressure that is coming from the drugs that are given to treat HIV.
Most of the mutations for drug-resistant mutations were among those patients who were receiving only 3TC, 3TC and other antivirals, but those other antivirals do not have effect on Hepatitis B virus. Mm-hmm. So the only active antivirus that can have effect on Hepatitis B virus was 3TC contained in the regimen. So in those patients, the drug resistance mutations were high, mm-hmm. which means the presence of 3TC may have a selection pressure for drug resistance mutations. Uh-huh. But if it is, the recommendation is this should be combined with other antivirals that can have also activity to Hepatitis B virus. So the recommendation is 3TC has to be combined with TDF in HIV Hepatitis B virus co-infected patients.
Okay. So I'm checking again. I don't see any question or Q&A on the chat. But I do have an additional question, and this is not directly related to the science, because I think one of the goals of GOHi is capacity building and understanding what are the challenges that exist at doing the type of work that you did. So for people that are listening to you and that would either are involved in the similar studies or would like to start similar studies, what can you tell us about the main challenges you found on the way while you were doing this work?
Yeah, basically, we were collaborating with University of Calgary, and of course, this work was not actually led by me. There were other people in our university too. So I was a co-investigator in this research. So the problem is related with capacity to do molecular works like sequencing and even PCR. So trainings and capacity building in terms of those equipments would help to facilitate researches, similar researches like this one. So mostly the problem is related with resources, supplies for PCR and equipment. Otherwise, the patients are there. You can find any patient for any disease. So the context is really good to do infectious disease research if we have those capacities, particularly laboratory equipment and certain level of training for people working in the area.
Okay, so we have someone who have raised hand. So Zelalem, do you want to ask your question? Zelalem Mikuria.
All right. Thank you, Dr. Boyaga, for the opportunity. Dabas was such a wonderful presentation. Thank you very much. I have a couple of questions, if I may. The first one, you talked about these different genotypes. For example, HPV, you find genotype A to be predominant. And then when you look at the occult one, you found a genotype D, the dominant one. So from a clinical perspective, what I'm trying to understand is if when someone is diagnosed with this occult type or active HPV, the treatment regimen, is that any difference? Because you mentioned for treatment response, knowing these genotypes is so crucial. So along in that line also, when you talk about genotype D, so the sole means of detection seems like detecting the DNA in the serum, and you profile the mutations very well. And then in there, I wanted to know if there is a signature mutation associated with this occult type of HPV infection. That would be really critical in terms of, for example, clinically, if there is a signature mutation associated with the occult HPV type, then you may probably design a particular PCR targeting only that signature mutation, and then can identify clinically the occult type with the active type, things like that. Can you give us, can you elaborate on this point? Thank you very much.
Okay, thank you very much, Dr. Zalala. So regarding the genotypes with treatment, basically knowing that the genotypes, the different genotypes will give us a clue about their treatment option, or we can predict their treatment response. We can also predict even their mode of transmission and the possible clinical outcome or disease progression. So if we consider transmission, mode of transmission, for example, genotype B and C are mostly transmitted vertically than other genotypes. And when we consider treatment, the treatment for Hepatitis B virus may be nucleoside analogs, drugs that we use for the treatment of HIV can be options. For example, lamivudine or tenofovir can be treatment options, but the other treatment option can be interferon-based treatments. So mostly for the interferon-based treatments, knowing the genotype is important because some genotypes respond properly to interferon-based treatments while others do not. For example, genotype A responds very well for interferon-based treatments compared to other genotypes, even genotype B. So to consider treatment options, knowing these genotypes is important. The other issue is related with the genotypes in occult and in overt or hepatitis B surface antigen based and nucleic acid based testing. So I don't know what happened. Basically, in overt hepatitis B virus, we found this genotype A being the dominant one, around 40+%. But in occult hepatitis B virus, it's more than 80% of the genotypes were genotype D. So from this, we can conclude that most occult hepatitis B viruses, virus infections are mainly caused by this genotype D. It may need further study, but from our observation, from our finding, we can see that the dominant genotype is genotype D in occult hepatitis B virus infection. So when we see the mutations, so the mutations that we have tried to see is related with drug resistant mutation related to risk of developing hepatocellular carcinoma. So the mutations in the P and or the polymerase and reverse transcriptase genome are related to drug resistance, as the drugs are targeted to non-competitively competitively inhibit the activity of this enzyme, while the mutations related to pre and core genes are related to development of hepatocellular carcinoma. And in both cases, in overt as well as in occult hepatitis B virus infection, the drug resistant mutations are similar, the markers are similar. We didn't come across with a signature type of mutation for this occult hepatitis B virus infection so far. So the mutations are related with development of hepatocellular carcinoma and drug-resistant mutations. And if they happen, they can happen in both overt hepatitis B virus strains as well as occult hepatitis B virus strains. And we didn't come across with a unique mutation associated with occult hepatitis B virus infection so far. Over.
Thank you.
Okay, so I don't, let me see if we have additional questions. Question open. No, I don't see questions. I see messages of congratulations for good presentation. So without that, I think that's a very good segue. So again, join me to thanking the Basus for a very nice presentation. That was very informative, and thank you for a very nice presentation and very nice work. So then this concludes this session. So thank you all for joining, and Global One Health, do you have any last message for the participants?
Yes, thank you so much for moderating for us, Dr. Boyaka, and thank you so much for your wonderful presentation, Debasu. Apologize about our speaker, Dr. Bayoki.
Mhm.
And so our next webinar will be on September 17th, and we will be discussing the wildlife interface with Drs. Cheryl McCrindle and Rudovic Kazwala presenting, and our moderator will be Dr. Tanya Bergerwolf. So we look forward to meeting with you then. Thank you very much, everyone, for joining us.
Thank you.
Okay, thank you.